Some of the cranial nerves and the equipment that you have. So the first one is cranial nerve number 1, which is olfactory. We do have some common sense. So this is not going to be a surprise to you all because there's only 2. All right, Camille, I'm gonna look at your nares and make sure they're unobstructed. Okay. All right, close your eyes for me. All right, I want you to pinch the right side of your nose closed. Okay. All right, take a deep breath in. Your nose. Can you tell me what that is?
Cinnamon?
It is. Okay, let's make sure you don't get this right next to their nose. We don't want them to inhale it. All right. All right, same thing, close your eyes. Nope, still a fluid on the other side. Okay. Deep breath in. All right, we're gonna do the same thing, so I'll fluid the other side. The other myth, but we're gonna do it anyways. Okay. Now, please don't let them inhale this into their nose. Okay. That is smell. All right. Optic. We're gonna do visual acuity. So we'll do the smelling here in just a second. We have a light on their table. Yes. Yeah. Right. All right, so I'm gonna have you kind of angle this way so they can see. I demonstrated this in class, the confrontation test, right? Okay. All right, so I'm gonna have you cover this side. Okay, do the same. All right, I'm gonna do the pen light out to the side, and I want you to let me know when you see the pen light come into your peripheral vision, okay? Okay, perfect. So you test both eyes. Once again, your peripheral vision has to be intact. Otherwise, you can't accurately measure if what she's saying is appropriate, right? Honestly, she was seeing it a little smidge before I was. And so her periphery is a little bit more intact than mine. Okay. With the Snellen, okay, you guys remember how far we stand away from the Snellen, right? 20 feet. Okay. With that being said, we have a very special Snellen chart in this lab. I don't know where on God's green earth they found this thing.
Did they find it?
No, I'm talking about the special one we have.
Oh, yes.
Okay, back here on this door. Y'all notice some things missing from the top? The E. Okay, so whoever walked this down this, whatever, is probably after we built. It's meant for 10 feet because it's missing part of the chart. So when you do your screenings today, we're gonna have you stand your person at 10 feet. Okay, so just have them walk about 10 feet from this. All right. It will convert. Okay, so what you'll need to do is your screening. All right, Camille, come over. But I want you to know, in general, Snellen is 20 feet.
Yes.
When you have the full chart. Okay. All right. All right. Go ahead and take 10 steps back from the door. Okay. So if you see it on the exam, it's 20 feet. Okay. I'll be like, well, what in the lab? No. Being correct, it's 20 feet. Well, Courtney said no. Okay. All right. Let's see here. Can you read this line? I usually don't start at the top. I try to see. Can you read this line? You try. You got pretty close.
Dang, somebody made him some carrots.
So,
I was like,
okay. I ate all the carrots and I had like 2,000 visions. So, all right. So she read most of this line correctly, so I would give her this. So it's gonna convert. So when you walk, if you're the one examining, at 10 feet, so it says she's 10/8, but it converts if you fall it over to this side, so her vision is 20/16. So she's better than 20/20. Okay, eyes. So that's with
Eyes
both.
are eyeing.
So that's with both eyes. Okay. And then you're gonna. Yeah, so then
I
you're
got
gonna-
glasses.
so you're gonna do it with both.
Where are they?
Each
In
one,
my
each
backpack.
So I have a question.
Yes.
So 2016 means she sees at 20 feet what others see at 16 feet,
Yes.
and that's good.
Yes, that's better than perfect vision.
Okay.
Overachieving.
So we did that.
If you don't
At
need
least you
glasses,
have
you need more.
access to.
Epic.
You're welcome.
She sees at 20 feet, but the average person sees at 16 feet. So her vision is better
I'm
than
just trying to set the
20/20.
bar. She said she saw you, she saw you.
Okay. Alright, so we're gonna quickly just demonstrate one eye at a time, so I'm gonna bring you down here to the 20/20 vision line and see what you can read with the right eye. This one. You see how both eyes work together?
It's all blurry, yeah.
Okay, why don't we try this one? Okay, so I would say she's probably 20/25 in the right eye. Okay? Alright, so let's do the left eye. Alright? Let's start at the 20, actually she was 20/25. So let's start at the 20/25 line. Can you read that one at all? Alright, so I would say right eye 20/25, left eye is 20/20. But together she is able to create vision together as a 2016? 2016. So you can see how one eye can be different than the other, but together they accommodate and create a better overall vision the way you're seeing. So. Alright. So that's the Snellen. Follow me, Camille. Let's see what else we have left. Alright, so station 2, we're following along. I've already assessed the pupils under that on Robert, so you just want to note size, reaction pupil, shape. Let's see. The palpable fissures are here, so you want to make sure that they're equal and symmetrical, the openings. So like as you look at, you're looking for ptosis basically. So as I look at Camille, I don't see that like one eyelid is droopier than the other. So I hate the word palpebral. It makes it sound like you're gonna palpate it. Don't palpate anybody's eyeball. Okay? We're not qualified to do that. So you're looking at the opening between the lower lid and the upper lid, and you're making sure that they are equal and symmetrical. Okay. So that would be ptosis.
Yep.
So if you saw a saggy eyelid where the opening was much smaller on this side versus this side, that would be ptosis.
Would Stice cause that?
A sty? Not necessarily.
I've had styes.
I've had one as well. My daughter's had one. It just depends on the size and the location, because they can really be anywhere on the lid.
They would tell you if they don't have these you know, say,
And that's
I got
different.
one. Yeah, that's.
So a droopy eyelid is different than lazy eye. Okay. All right, we'll get there. Let me see if it's on here. So no ptosis noted. All right, how do you How do you test for extraocular movements? You guys remember?
Is that the 6 phases?
Yeah, the 6 cardinal fields of gaze. Once again, we have the most amazing names for things.
Why couldn't it be like wildcats?
Yeah, the 6 wildcats fields of gaze. For those of you that don't live here, the Louisville and
Yeah.
Kentucky rivalry
Very
is a
well.
big thing. Angie and I are clearly UK fans. Okay. That's too bad. All right, little brother. All right, here we go. I'll talk trash all day. All right, let's go. All right, so I'm gonna have you follow my pen. Keep your head still. Just move your eyes only. Okay, so you guys want to watch Camille's eyes. Okay. Okay, so her extraocular movements are intact. I'm not seeing any nystagmus, which is shaking of the eyes back and forth, and I'm not seeing any strabismus. So strabismus is technically that lazy eye. So seeing the eye kind of rolling inward, so you might see the eye kind of roll inward or outward. Either one could be considered a lazy eye. So just having like a droopy eyelid is not really a lazy eye, okay? All right. Eyes are not my specialty, by the way. All right, let's see here. All right, so next is the trigeminal. So we're gonna assess the TMJ. All right. So I am gonna have you bite down, like clench down like this. Okay. All right, clench down again for me. All right, there we go. Perfect. Equal strength bilaterally. All right, I'm gonna have you close your eyes for me. Okay. She's like, I'm trusting you. I can pass. Yes, you can. If not, we're gonna have some problems. All right. I'm gonna have you close your eyes for me. You're gonna feel me touch your face on both sides, either with something that is soft or a little bit sharper. Neither should really hurt. So what I want you to do is you're gonna identify whether it's soft or sharp, and identify where you're feeling it on your face, okay? All right, ready? Soft right cheek, okay?
Trust issues. Sorry, guys.
Okay, so where did you feel that?
Here.
Was it soft or sharp?
Soft.
Okay. Sounds great. All right. All right, close your eyes for me, please.
Trust issues. Sharp right side forehead. Sharp right cheek.
You're like right eye twitches.
It was here,
I
sharp.
probably would do the same thing.
You just never know, soft.
You just never know. It might harm me with my cotton ball.
Soft left chin. Soft, or not soft, hard left chin. Hard left cheek. Forehead, sharp. Soft left cheek. Soft left forehead.
Okay. You did good. Intact. Trigeminal nerves intact. All right. The facial cranial nerve, we already did that with Robert. Looking at the facial movements, everything should be symmetrical. You're not seeing any drooping of the face on either side. All right. With the acoustic exam, all right, Camille, I'm going to stand kind of situated behind you. I'm going to whisper some words. And I want you to
Med surg.
Or, yeah, I'm gonna whisper some words or something, and I want you to be able to repeat it, okay? So I'm gonna have you cover this ear for me, or press it on your tragus, okay? All right, you ready? I'm thinking, hold on.
I was like, did you say? 3. Med surg.
This is so creepy. I've never done this to a patient ever. Just back here speaking into your ear.
health assessment.
Okay. All right.
Should have said med-surg.
I know, right? All right, so the other hearing tests are not on here, but I do want to show those to you because we talked about them in class, and you can practice them if you want to. All right, so the first one is the Weber test. Anybody remember how to do that one?
Is that with the tape?
Yes. All right, so I'm gonna strike this, and I'm gonna place it on top of your head. I want to know if you can hear it in both ears or just one ear or not hear it at all, which hopefully you're hearing me, so you should be able to hear it. We hope. All right, I just warn you, it's gonna be loud and yeah. All right, ready?
I hear it in both ears.
Ugh. To make it stop, just grab it, okay? All right, the Renee test.
You tap it again and then put it here until it goes away, then hold it here to reach it from here.
Right, so we're gonna tap it, we're gonna strike it again. We're gonna place it on the mastoid bone behind the ear, okay? Once that sound goes away, you'll need to tell me. So then I'm gonna pull the tuning fork out in front of the ear where the opening is. You should be able to still hear that, okay? All right, here we go.
I don't hear it. I hear it. No, it isn't.
Okay. So you can see bone conduction is less than air conduction. Okay, so that's a normal finding. All right, so if I were to move this in front of her ear and she heard nothing, that would tell me she probably has some sort of obstruction in the ear canal that's blocking sound from getting through. Okay,
And it's not about time or anything, it's just the ear.
it's just about, what was the question?
It's not about the time of how long she's hearing it, but it's just the fact that she can't hear.
Yeah, all I want you to know is that air conduction is longer than bone conduction. Yeah. Usually, your air conduction is about 2 times as long as the bone conduction. You don't really need to know that, but if you're curious, you will not learn that in med-surg. Okay, so next we're gonna test the glossopharyngeal and vagus nerve. You have seen there that I have something marked out. We're not testing the gag reflex. I do not want people vomiting in here. I don't want to hear people like retching and gagging everywhere, because then I might sympathetically vomit for you. Up at the top here, there's something else marked out. We used to test each other's corneal reflexes, where we would take like a cotton ball, and we are not doing that. I don't need damaged eyeballs. We don't need lawsuits, okay? So we're not doing that either. Got it. Got it. Toothpick. No. Do not do that. All right. So no corneal reflex testing, no gag reflex testing. Okay. So for this one, all I'm gonna do is have Camille open her mouth and say, ah, stick your tongue out, like you're at the doctor. Ah. Okay. Her uvula is midline. Good. And as we've been speaking anyways, but her voice sounds are smooth and coordinated. All right. Spinal accessory. We're gonna do that shoulder shrug. So I'm gonna go ahead and just lift your shoulders up for me. Okay. All right, lower them down. Now we'll do it against resistance. Perfect. All right, now I'm gonna have you turn your head side to side for me. Okay. All right, now I'm gonna place my hands on each side of your head and try and go against my resistance. Okay. All right, so that's what you do for that one. Let's lift. All right, hypoglossal, which we've kind of already done hypoglossal in a way. Go ahead and stick your tongue out for me. Okay, it should be midline. What you could do, and we're not doing this, you could take like a cotton gauze and grab the tongue and try to have her move her tongue against your resistance. We're not doing that either, okay? COVID, you know, like we don't need to be touching people's tongues. She said we would clearly have gloves on. We've been speaking this entire time. Her speech has been clear and articulate. Okay, cerebellar function, we've already done the Romberg. We're gonna do rapid RAM, so I'm gonna have you do this movement for me. Okay, so that is good. The finger to nose test. So if you'll just angle this way for me so I can see. All right, I'm gonna have you place your finger on your nose. You're gonna come out and meet my finger. Go back to your nose. Finger, nose. It's a little challenging. Okay, so that's the finger to nose. The finger to finger is where we did this in class yesterday, where you stand like this. So you'll, yeah, and you go like I did the first time I did this. So arms out to the side, and you're gonna bring your fingers to a point in the middle. Perfect. It is okay if they miss just a little bit, but like if you're doing like this or like one arm drops, that's abnormal finding. Okay. All right. All right. Let's sit back down. All right. Now have you close your eyes for me again? Trust issues. All right, so I want you to tell me, now with superficial touch and pain, usually this will be specified for the person you're assessing. So if you're worried about like diabetic neuropathy, you would be down at the feet, assessing the feet, the lower extremities. If someone's having like numbness, tingling, maybe in the hands because of carpal tunnel or something like that, you would be assessing maybe the upper extremities, the hands. So it's really gonna be situational, just depending upon your patient. You are not going to be going room to room doing all of this on every single patient you take care of. Okay, that's excessive. But just know that if you do have someone who is neurologically impaired, maybe they've had a brain injury, they've had something happen, a stroke, you may be doing some of these cranial nerve exams. Okay. All right, Camille, I want you to tell me where you feel the touch and whether it is dull or sharp. Okay. She didn't say anything. Did I actually touch it?
Barely. That was a trick question. It was soft pinky. Soft middle. Hard middle.
Okay, so that is soft, sharp versus dull. You would do the same thing on the feet, but you don't need to take everybody's shoes and socks out. All right, close your eyes for me again. Once again, you have to trust me. Okay. All right, if you will, yeah, perfect. I'm gonna place an item in your hand, and I want you to try and identify it for me, okay? It's not a spider or a snake. My daughter thought would be funny. It's like, yeah, let me just go to the Herp Aquarium in the hospital and grab one of those. All right. A coin. Okay, perfect. Keep your eyes closed, please.
A key. Paper clip.
Okay. This is just placing familiar objects in their hand and having them identify. All right. I'll have you close your eyes for me. I'm going to draw a letter in your hand, and I want you to identify it, okay? This is the top, this is the bottom. S.
T.
Good. Do that this one.
B.
Good. All right, so that is graphesthesia. All right, so last is the reflexes. Is there a hammer? Sounds go off and I'm like, oh God, exams are posted, something's posted. Everybody panics. People start crying on the street. Like, what's happening? All right, so I'm gonna assess Camille's patellar reflex. We learned in class the different spots like the biceps, brachioradialis, triceps. We are only going to assess the patellar reflex, okay? All right, so I'm going to have the patient ideally sit on the edge of the bed with the feet dangling. It's the most ideal situation, okay? All right. So I'm going to feel for this little soft groove here. All right, Camille, just focus out there. Ready? Everybody see that? Just a little bit. That was a 2 plus, okay? Everybody's like in amazement, like. Okay, do this one. Ooh. Okay, that was probably a close to a 4. Okay, just relax. It may be the way that she's sitting.
You hit it right.
Oh, okay. Much less that time. There we go. Okay, so you are grading the deep Trigeminal reflex. With assessing for clonus, what you're going to do is you're going to have the foot, you're going to dorsiflex it back, and then you're going to quick release. You saw how her foot just naturally went back to its position. What you're watching for, if they have a positive clonus, are the beats of the foot, and you're going to count the number of beats if you see that. Okay? All right, let me see if there's anything else.
How would you document that, like, clonus?
Positive
or-
clonus, and you document the number of beats.
Okay.
So positive clonus, 3 beats. Positive clonus, 2 beats.
And that's normal to have positive clonus.
No,
No, no.
It's not.
no, that is not known. No, so you saw what her foot did. It just went back to its normal position.
Okay.
Yeah. So when you have clonus, when you're having someone who has 4+ reflexes, it means that the central nervous system is very excitable, and it's essentially your central nervous system is in overdrive. Okay, we don't want to see that. Okay. Because when you have something like that, the biggest concern, seizures. If it's that excitable, we're worried about the patient seizing. Okay. All right. What else? Oh, the Babinski. Would you mind to take your shoe off? You leave your sock on. All right, so I'm going to test for the Babinski reflex. Just remember, anybody that's greater than 1 year of life should have no positive Babinski reflex, okay? All right, so hold her foot here. So what you're going to do, you can use anything. You can use a pen light, you can use this. Okay, this may tickle a little bit, okay? All right, ready? So did you see how her feet kind of curled down? That is the normal response, okay? Now, if I did that and her toes fanned out like this, and I had extreme dorsiflexion of the big toe or the great toe, that would be a positive Babinski reflex, okay? And that is an abnormal finding. That tells us that there is in an adult, anybody greater than 1 year old. So in a 2-year-old, actually in someone who's 14 months, is an abnormal finding. Okay, so the Babinski disappears by 1 year of life. Okay. Any questions? Y'all ready to practice like